Today, we are looking at a video from Dr. Gautamukula S. Raju's channel. It's titled Surgical Anatomy Colostomy. And on the surface, it's a technical guide on rerouting the human body. But if you actually watch it, the real takeaway isn't just about where the colon goes.
No, it's actually a lesson in logistics. It's about how a major anatomical change, well, it forces a change in every single routine interaction that follows.
Exactly. So the mission for this deep dive is to understand that the colostomy, but specifically to pinpoint one critical non-medical error that providers make during follow-up care.
Right, it's a mistake that has nothing to do with surgical skill and everything to do with situational awareness.
Let's start with the plumbing. The source defines a colostomy pretty simply as opening the colon to the anterior abdominal wall. Usually this is happening because of rectal cancer, right?
Yeah, specifically cases where the surgeon has to remove the rectum and the rectosigmoid. That's the curvy section of the colon just above the rectum.
So you've removed the natural exit.
You have. So the surgeon takes the remaining healthy section, which is usually the sigmoid or descending colon, and brings it out through the belly to create a stoma, a new exit.
Which necessitates a colostomy bag to collect waste. Now the source shifts gears here. It moves from how we build it to how we maintain it. Specifically, what happens when that patient needs an endoscopy later.
This is where the autopilot tends to fail. If you've ever had a colonoscopy, you know the drill. You lie on your left side. That's the left lateral position. It's standard.
But Dr. Raju points out that for a colostomy patient, that standard is wrong.
Completely wrong. You have to flip them to the supine position.
Flat on their back.
Right flat on their back. It gives you the best access to the stoma.
That's a physical adjustment. But the part that really stuck with me was the bag rule. This feels like the core insight of the whole video.
It is. It's a protocol to prevent a disaster. When a patient comes in, you have to remove their existing bag to insert the scope. But before you touch anything, you have to ask one question.
Did you bring a spare?
Sounds trivial, doesn't it?
It does, until you think about the standard medical workflow. In a hospital, used supplies are biohazard. You take off a bandage, you trash it. You take off a drape, you trash it. Muscle memory says, remove the bag, throw it in the bin.
And that is the trap. If the patient answers, no, I didn't bring a spare, and you've already tossed their old one.
You've stranded them. They have no way to collect waste for the ride home.
Exactly. So the source is adamant, do not throw it away. If they don't have a spare, you have to carefully preserve the dirty bag, set it aside, and reuse it after the procedure.
It's such a clash between hygiene protocol and patient reality. You're technically supposed to discard waste, but in this specific context, that waste is the patient's dignity and security.
It highlights that technical competence, knowing how to navigate the scope inside the colon, is useless if you lack the logistical empathy to manage the equipment on the outside.
It really frames the colostomy not just as a surgery, but as a lifestyle ecosystem that the doctor has to respect.
Ideally, sure. But it boils down to checking your autopilot.
Which brings us to a final thought for you to mull over. We rely on standard operating procedures, like throwaway used items to keep hospitals safe and efficient. But in this case, a patient's entire well-being hinges on a provider pausing that routine to ask a single question.
Did you bring a spare?
It makes you wonder how many other standard habits in our daily work might actually be creating a crisis for someone else just because we forgot to check the context. Thanks for listening to this deep dive.
Stay curious.